not only difficult, but to start with, there will be lots of obstacles. To be honest, I really don't need a presentation, PowerPoint presentation for this talk, but for more clarity and to have certain guidelines of what I should be speaking, I've made this. Now it's been almost 18 years that I've been practicing ROP in private. So I started ROP in a private hospital in Punjab in 2007, and now I regularly screen babies in about 5 NICUs, irregularly visit in about 3 more, and 15 to 20 NICUs refer cases to me. And overall, these NICUs are spread over Punjab, Haryana, and Rajasthan because I am working in a place which borders all 3 states. So when we talk of the real world experiences, it could be in 2 forms. One is this presentation of the ROP of the baby looks different from the book picture. When it's a book picture, things are very clear, as Dr. Subina just mentioned. When it's type 1, treat, type 2, just observe. But when you see these babies, especially who are from NICUs where the quality of neonatal care is poor, then their presentations are very different, and you are in dilemma whether should I treat, should I ask my senior, what should I do? And you don't have a facility of REDCAM to document it. And the second thing is the logistic challenges in these all treatments. And most of the people who call me on phone, the doctors, young doctors, they have questions regarding the second point, which is logistic challenges, and that's today my presentation will be dealing more on that. So what are these logistic challenges? As per me, so when you have a baby in your OPD whom you have seen and decided to treat, so then where should this baby be treated? This is a very frequent question which many young people ask me. Should you treat it in your own hospital, or should you treat in NICU? If you want to treat in your own hospital, you should have availability of a reliable anesthetist and equipment to deal with any sort of emergency. Now remember here that this anesthetist may not be ready to come to your hospital just for one baby because you have not been calling him regularly for other surgeries which you usually do, topical or peribulb or things like that. And as for myself, I always treat these babies in a NICU where their staff is geared up to deal with any emergency. In all these years, I've had 2-3 emergencies and they were very well handled by the NICU staff. So I don't treat these babies in my own hospital. Now, there could also be a scenario when this baby has come from a distant town. The NICU in your own town is not where this baby was from. Now, where do you treat this baby? So again, treat in NICU, local NICU, talk to the pediatrician from whom this baby has come. And sometimes the parents and the pediatrician don't want to pay the charges of this NICU where you're going to treat, because this NICU is going to charge for taking care of this baby. So that let this be the neonatologist's headache from whose NICU the baby has come. Sometimes these neonatologists, they are friends with each other, or he calls up this neonatologist that please waive off the charges, and this neonatologist from where you're treating really does also so. So you just take your own charges. What should be your charges? Make a balanced approach. Don't charge very high, but also please don't charge very low. This is a niche area. This demands a lot of practice, and you have really worked your ass off to learn this. And they should have some respect for what you are doing. So have a balanced approach for charges. NICU charges are to be paid extra. And sometimes there will be parents who will not be able to afford these charges. So don't let this baby go blind. Have a list of philanthropic friends. They will be more than happy, to sponsor this treatment. Other challenges then is machinery issues. You could have a breakdown of machinery. So you should have at least one reliable backup VRS, a vitro-retina friend who will lend you his machine. He could be your friend, or he could be even your competitor. So next time, once your competitor asks you that do you have an extra Ozurdex with you today, mine is finished, kindly do lend him, because tomorrow you may need to borrow his machine. So on consent, I'll also be dealing in detail in the next slide, but I get all the consents written fresh every time from every parent. This way they understand better, and medical legally we are on the firmer ground. And once you have done the laser, I believe baby should be kept in the NICU for at least 12 hours. 2 of my babies have had problems while going back home when they were discharged within 4 to 6 hours of treatment. One baby even died, I remember. So the consent should include very, very clearly the consent for ventilation if required. It should include that the child may die because during the procedure, possibility of non-regression or progression of the disease, and further expenses needed if more treatments are required. And also need to go to a higher center, because the parents sometimes raise the issue that you never told us, now we'll have to go to another hospital. So it should also include the chances of refractive error coming up as a child grows up, and the child not being able to follow certain career choices. Only last week there were parents who said that this is my child's decision, that would be when he grows up. I said, okay, then fine, let the child take up the decision. If he is blind, then what will you do? So this is the thing, you should clearly tell them that he may not be able to join the armed forces or aerospace or something like this. And keep these consent papers with you till the time you practice, because they can sue you even later on when the child grows up. So laser, as I told you, since I am going to NICU to do it, my aim is to finish the treatment in one session only, unless and until really contraindicated or not possible. And while I am doing the laser, I always call the parents in to show them what laser is, how it is done, how painstaking it is done. And after the laser, immediately also the baby is shown to them that baby is doing fine. And midazolam, if the baby is a little heavier, really makes the life very easy. And NICU staff is all geared up for giving midazolam. For them, it's not a problem at all. Now I'll come to clinical dilemmas which come. So you see this picture that I have drawn. I'm sorry, I don't have real photographs because I don't have facility of red cam with me. These are the babies, which are usually bigger and heavier babies. And the blood vessels, the larger blood vessels are usually into stage zone 2A and even sometimes reaching zone 3. And as you see that red thing, these are the little blood vessels, capillaries, precapillaries and everything, arterioles. They are just as if they've been wiped off with an eraser. This is what happens when these babies come from a NICU where quality of neonatal care is very poor. So what do you do here? There's no staging here anywhere. There's not even AROP because there are no new vessels here. So in these babies I've been giving anti-VEGF and they do very well, and most of them even don't need laser later on. This is the second picture where the blood vessels now are in zone 2. There is no plus, or maybe somebody will call it a pre-plus. There is a ridge which is touching zone 2P. But you see these red dots, these are clusters of sort of, you can say, popcorns as we call them, but they are really what I call them is start of extraretinal neovascularization. You don't really need a frank plus for this to treat. If you are seeing these clusters increase over 2 or 3 visits, treat this baby. Now this picture shows stage 3 plus in zone 2, and how you see these black things, these are little islands of demarcation lines and ridges in zone 1. Initially I used to laser them. Now when these kids are brought to me later on, I see these laser marks in zone 1. I ask this question to myself, why did I laser them here? I think they should be left alone for the time being, just cover the periphery and they will vascularize. Because they look very bad once the child grows up and child goes to another ophthalmologist, he will think, what have you done? Now see, here you have 1 to 2 clock hours of extraretinal neovascularization in zone 2A or zone 3. There is no plus disease. What would you do here? This would be like, smoldering ROP, what we call. Again, I observe this baby for many weeks continuously, and if this is not regressing on its own, or I see it's little increasing every time, again I laser this peripheral avascular retina in these areas. This is a picture on the left side, top picture taken with a mobile phone, and other pictures were given by Dr. Simarajan. When I referred this baby to him, I was so confused when I saw this baby. You see all these blood vessels. It looks like as if this child has some retinitis, some vasculitis. I really did not know what this was. So sent the baby to PGI and they said it is ROP. And these are the angiograms. You see the extent of capillary non-perfusion, the ischemia. Gave this baby anti-VEGF and I was told the baby is doing quite well. Now recently I also, again the real life situation, I had this one baby, 28-weeker. So initial 2 exams just told about immaturity of retina, and at the 3rd exam at 33 weeks the child had already developed AROP when I gave injection ranibizumab biosimilar in both eyes. And 2 weeks post injection I saw that one eye was really not doing well. Plus disease was there, other eye was doing well. So I now, even after 2 weeks, I had to repeat the injection, and this time I gave Avastin in this eye. Post injection follow up, I did 1 weekly for 2 times, and then after 2 weeks. So at 4 weeks post injection, when this baby comes, he had stage 2 plus in one eye, right eye, and vitreous eye hemorrhage in the left eye. And I was really scared what to do. So I did laser in right eye, and for left eye referred the baby to PGI, where they did added laser first of all, then they did LSV, and I was told by Dr. Simar that right eye has stabilized, but left eye is still not stable even after so much. So this is, some babies will really do bad whatsoever you may do. So when we see again in real life, you see this is the kind of work I am doing. This is the total number of screenings I do, and birth weight ranges all the way from 650 to 3,000 grams. As we know, in India we have ROP in higher birth weight babies. But you see a lot of AP ROPs and hybrids in this cohort, that 7% approximately. Now see the treating person, that is myself, is the same. However, you see where I've written Bathinda here, 50, any stage of ROP is approximately 63%, whereas in another center it is 46%. So the fault here is not with the person who is doing screening and treatment, but lies with the NICU somewhere. And see, as far as treatment requiring is concerned, again in the Bathinda area we have 51% treatment percentage amongst any stage of ROP, and 32% amongst the babies screened, whereas these figures are quite low in Kot Kapura's centers. In spite of babies having a lot of AROP and hybrid ROP and zone 1 and 2, the results you see here, out of total 110 with zone 1 and zone 2P, we had good regression in 105, which is 95.6%, and only 5 had to be referred for further. So if you timely treat your things, even in your private practice, you can really have good results. Thank you very much.